Good afternoon. Why don't we go ahead and get started? I know it's Cinco de Mayo, and thank you guys for being here during your lunch hour. So I want to talk about insomnia. Can you guys hear me okay? So insomnia is a common complaint in a general medicine clinic. We see it a lot, and most of the literature seems to be really geared towards the sleep specialist. So I really wanted to sort of address some of the challenges we face and some of the management from just a general internist perspective. Before we talk about insomnia, let's talk about the functions of sleep. Really, the purpose of sleep is not fully understood. There are multiple theories about it. The most common train of thought is that sleep tends to revitalize the body and also promotes learning and cognition. And so this may explain why people who suffer from insomnia have impaired cognition, the following day. But the bottom line is sleep is necessary, and a lack of sleep is associated with increased mortality. So if you remember the REM sleep, this is when you have the sort of episodic rapid eye movements. This is the dreaming. This is where your muscles relax, and this occupies about 25% of our sleep time. And then there's non-REM sleep. This is about 75% of our normal sleep time. And this has the stages, stage 1, which is light sleep, and it progresses to our stage 4, which is delta or deep sleep. So what are some of the issues in the clinic related to insomnia? Well, first of all, just the definition. Many patients will come in and say, I'm having trouble sleeping, I have insomnia. And as an internist, I think we typically say, well, let's make sure other causes have been ruled out. A lot of studies have shown that insomnia has been really underdiagnosed and undertreated in primary care. Sometimes patients may not report the condition to their primary doctor. And then there's limited resources. Some of the management strategies like cognitive behavioral therapy may not be available in many settings. And also clinician comfort with prescribing the medications to treat insomnia. So how common is it? Well, it's the second most common medical complaint after pain in primary office settings. There's over 5 million office visits per year. The prevalence increases with age. It also has a higher prevalence among lower socioeconomic status. Why do we care about this? Well, as I mentioned before, insomnia is associated with an increased risk of mortality. This was a study out of Pennsylvania that looked at over 1,700 men and women who slept less than 6 hours, and the mortality rate for men was 21%, and for women was 5%, and for men was 21%. Also, BMI. I mean, this frequently comes up. Insomnia has been associated with increased risk of BMI. Patients who slept less than 6 hours were found to have as much as 1.7 kilograms per meter square to be heavier. Also found to have 3.4 centimeters more girth. So they discovered there was a sort of inverse linear relationship between BMI, waist circumference, and sleep duration. So this was a study from 2014 when they looked at people who slept less than 6 hours and stroke. And actually, it was discovered that women between the ages of 18 and 44 had there was a higher prevalence for those women to have stroke if they slept less than 6 hours. So what's the diagnostic criteria for insomnia? Well, the International Classification of Sleep Disorders describes it as difficulty initiating sleep. You may have difficulty maintaining sleep, waking up too early, despite an adequate opportunity for sleep, an adequate environment for sleep, and there's also deficits in daytime function. And all of this is not better explained by another sleep disorder. So some of the deficits in daytime function has led to insomnia really being considered a public health epidemic. Some of the issues are fatigue, poor concentration, social dysfunction, daytime sleepiness, increased accidents. People who slept less than 6 hours were twice as likely to be involved in an accident. And also, the patients, they worry about not being able to sleep the next day. And so they worry, oh, when I get home tonight, am I going to be able to sleep? So it's sort of a repetitive cycle. And then decreased job performance and increased absenteeism. And I think this is relevant, especially to our clinic, because as I mentioned, it has a higher prevalence in lower socioeconomic status, but also you have increased absenteeism. And when you look at absenteeism, there's the insomnia group in this study, they were absent 15.8 days, whereas the control patients without insomnia were absent from work 1.6 days. And so you can see a sort of theme developing where a person has insomnia, now they're missing work, and they're already in a lower socioeconomic class. Well, what are the general types of insomnia? So there's acute insomnia. So the symptoms are present for less than 3 months. That's considered acute insomnia. Usually there's an identifiable stressor. Maybe it's divorce, or family member passes away, or exam coming up for our clerkship students. But it becomes a diagnosis when the insomnia actually becomes the primary focus. Now, the insomnia may resolve when the stressor resolves, but a lot of times this kind of becomes the catalyst for those patients to go into to have chronic insomnia. Now, chronic insomnia, the symptoms occur at least 3 times per week for 3 months or more. The patients, again, they have an adequate opportunity for sleep, they have an adequate environment for sleep. Now, but some patients fall into the category where year after year they have these repeated episodes of insomnia that don't quite last the full 3 months, just sort of weeks at a time, but they still fall into the category of chronic insomnia. There's a significant overlap of psychiatric disorders and insomnia. A person that's diagnosed with chronic insomnia, they're 34 times more likely to develop a new psychiatric disorder within 1 year. And then about 45% of patients with chronic insomnia also have a psychiatric disorder. And a lot of patients feel like, well doc, if my depression was better controlled, if my anxiety was better controlled, then I wouldn't have insomnia. And so these patients, they get treated, and sometimes their anxiety does get better, their depression gets better, but they still tend to suffer from insomnia. And a lot of times in clinic, it's really hard to differentiate, is this a psychiatric disorder or is a patient having a primary insomnia? And here are some of the reasons, like for example, depression. Many people with depression have insomnia, fatigue, the daytime deficits, the difficulty concentrating, and the early morning awakenings. Many patients who have anxiety also suffer from insomnia, restlessness, fatigue. And then patients with panic disorder and post-traumatic stress disorder, they also have insomnia. And I think we see a lot more patients than we realize with PTSD who are suffering from insomnia. But there's a higher prevalence of insomnia in various medical conditions, pulmonary disease, cancer, heart failure, especially Alzheimer's as well as Parkinson's. And then it's pretty consistent from what I've seen in the clinic that when the patients complain of fibromyalgia, if we ask them, they're like, oh yes, doc, I can't sleep at night either. So you have to remember those associated medical conditions. Well, what about, like, in turn, is kind of what we do, the medications that we prescribe. There's a lot of our medicines that contribute to insomnia. Some of the bread and butter that we do are beta blockers, like propranolol, metoprolol, Pendolol. These can produce sleep onset insomnia, increased awakenings, as well as increased dreams. Also steroids, for example, prednisone has been known to cause increased awakenings and insomnia as well. And then our SSRIs and medications for smoking, our venlafaxine and our bupropion as well. So substance abuse and insomnia kind of really go hand in hand. 3 days ago in the clinic, we had a lady come in and she asked for something to help her sleep. So we took a good history, and she admitted that she does cocaine about 3 times a week. So we really suggested maybe not doing the cocaine, and then let's see how the insomnia does after that. And then that's the true story. Alcohol, caffeine, as well as, again, illicit drugs and over-the-counter medications and tobacco all contribute to insomnia. And we also want to remember that insomnia can be due to other sleep disorders, such as sleep apnea, restless leg syndrome, circadian rhythm, sleep-wake disorders, as well as periodic limb movements of sleep. And this is where the history comes in when you kind of want to keep this in your differential. So how do we diagnose insomnia? it's really a clinical diagnosis. A good sleep history is going to really make or exclude the diagnosis. We want a detailed description of the sleep problem. When are they going to sleep? When are they waking up? Are they having trouble falling asleep? Are they having trouble staying asleep? Do they wake up many times during the night? What kind of symptoms are they having? Are they hearing voices or hallucinating before or after they wake up? And what's their sleep environment like? When I was in med school and finances weren't as great, I lived in an apartment and it was just so noisy above me, and this made me think about that particular sleep environment. Also, any associated other conditions, like, as we mentioned, is the patient doing drugs, or are they on a medication, or do they have any other medical condition? So this is from the Annals of Internal Medicine as far as in the clinic. So when should we consider specialty referral for patients with insomnia? Well, if there's suspicion of an underlying sleep disorder, as I mentioned before. Also, if there's a poor response to behavioral interventions and drug therapy. But what happens in the clinic, a lot of times the behavioral interventions, as far as the cognitive behavioral therapy, may not be readily available. And so these patients are really looking to their primary doc to help them out. Again, a psychiatrist, if we think it's a psychiatric disorder, the pulmonologist or sleep doctors if there's a sleep disorder, ENT if we think that there's some airway issues, and then neurologist if we're thinking Parkinson's or cerebral vascular disease or dementia. So the management of insomnia, the goals are really to improve sleep quality, improve related daytime impairments, and some of I think it's good for us to know, even just to have an understanding of like the cognitive behavioral therapy, and also the medications, so the sedative hypnotics and sedating antidepressants and other behavioral measures are all included in the management of insomnia. So cognitive behavioral therapy has really been shown to be the most effective way to treat insomnia. The premise is that you're going to eliminate those factors that perpetuate or exacerbate the patient's insomnia. Approximately 50 to 75% of patients really do achieve improvement from this therapy. However, it's not readily available. There's a limited number of providers that are trained, and it's not practical in a busy medicine clinic. When you look at the number of times to do follow-up and what all it entails in a busy clinic, it just doesn't really work together. But the components of the cognitive behavioral therapy are sleep hygiene education, stimulus control therapy, cognitive therapy, relaxation therapy, as well as sleep restriction therapy. But we can take some of this and really help our patients with it, especially the sleep hygiene education and the stimulus control. So here's some of the components of sleep hygiene. You want to sleep only as much as you need to feel rested, and then get out of bed. Keep a regular sleep schedule. Avoid sort of forcing sleep. Exercise at least 20 minutes, 4 to 5 hours before bedtime. Avoid caffeinated beverages after lunch. Avoid the nightcap. Avoid smoking, especially in the evening. And do not go to bed hungry. But when you tell a patient this, also tell them that doesn't mean eat a large meal and then go to bed. So you have to remind patients of that. Adjust the bedroom environment. And also limit the time with the iPads and the televisions. And then try to get patients to sort of put their worries on the back burner if possible while going to bed. So stimulus control is basically go to bed only when you're sleepy. And again, don't watch the TV, read, worry. And the bed is mainly for sleep and sex. Get out of the bed if you're unable to fall asleep within 20 minutes and go to another room. Then return to bed when you're sleepy, and then repeat the cycle as many times as necessary throughout the night. We had a couple of patients that this actually worked for in clinic, and they were pretty happy about it. They were not happy when we suggested setting an alarm clock for them to wake up every day at the same time, even on days when they weren't working. And then do not take a nap during the day. Now, cognitive therapy, it really tries to correct any inaccurate beliefs about sleep. You want to sort of reduce their anxiety and worry about not being able to sleep. And that was a big complaint of patients who had insomnia. They were just worried that tonight's going to be another night where I can't go to sleep. And the therapists also use relaxation therapy. Basically, is to recognize and control tension. So they'll tense various muscle groups and then sort of a progressive relaxation along with guided imagery and meditation. Now, sleep restriction therapy is basically to maximize the time in bed for the most efficient sleep. And if if they aren't able to sleep, then they get out of bed and they just keep increasing the time in bed until it's just that they're in bed during the times where they can get efficient sleep. Now, the problem with this is that the patient's occupation. The therapists have to remember that, if there's a pilot or a truck driver, you might not want to be so stringent with their sleep restriction. So, as I mentioned before, a lot of times the cognitive behavioral therapy is not available. We can do the counseling to try to help our patients. But then, many of these patients are like, Doc, I'm still having trouble sleeping. I've tried the sleep hygiene. I've tried the stimulus control. What do I do now? And so these are just some of the guidelines when we start to prescribe medications. We want to use the minimal effective dose. Avoid medications that have a long half-life. Be aware of potential drug-drug interactions. We want to caution patients about the interaction with alcohol. Review potential side effects, especially the daytime sleepiness which recurs. And agree on an appropriate duration of use even before you start it. So you tell the patient, okay, we're going to try this for a month and see how it goes. Start with a GABA agonist for acute or short-term insomnia. And then look for a rebound insomnia once the medication is discontinued. Consider intermittent use of hypnotic medications when long-term therapy is required. And also consult the sleep specialist before we start any sort of continuous long-term therapy with the hypnotic medication. So what are the medications? You have your benzodiazepines, your non-benzodiazepines, your sedatives, the melatonin agonist, and the goal is really improve quality of life, improve daytime functioning. Remember to counsel your patients about the side effects, and then be mindful of possible addiction with long-term use. And I've seen times in clinic where patients are really reluctant to stop their sleep medications. They've been on it for years and like, okay, it's time to stop and try something else. And a lot of patients are like, no, doc, I need that. I need that to sleep. So which patients are at increased risk of side effects? Well, pregnant patients, there's increased risk of fetal malformation. Alcohol and sedatives can lead to increased respiratory suppression. Renal disease and hepatic disease can lead to decreased clearance of these medications. Pulmonary disease, again, increased respiratory suppression. And elderly, really patients over the age of 75 have had increased adverse effects with sleep medications. And then nighttime responsibility. So if you have a single mom or single dad or a person who has to make decisions for their job at night, you really want to be mindful of the medications that you're giving them. So when it comes to the treatment of insomnia is kind of broken down into 3 categories. So we'll talk about sleep onset insomnia first. Ideally, you want to give these patients a short-acting medication. This is a good choice for an initial agent. The duration is usually less than 8 hours, and there's decreased residual drowsiness and somnolence the next day. And this category of drugs, you have the Zolpidem, Zolpidem, triazolone, lorazepam, and Ramelteon. Okay. So sleep maintenance insomnia, we want to use a longer acting medication, but these because they're longer acting, they have an increased risk of hangover sedation, also increased in the side effects. And there's a couple of medicines that are FDA approved now for this. There's Zolpidem extended release, a low-dose doxepin, temazepam, and Eszopiclone, And then middle of the night awakenings. So there's 2 medicines for this. There's a specific sublingual Zolpidem as well as the Zolpidem. However, you want to make sure that these patients are going to have at least 4 hours remaining in bed before they take this medicine in the middle of the night. So when we look at the benzodiazepines, they bind to the GABA type A receptor subtypes, and they've been shown to decrease time to sleep onset by about 10 minutes. Now, a person who's having trouble falling asleep, this is an extra 10 minutes feels pretty good. They prolong the stage 2 sleep, and their increased total sleep time is by an hour. Anxiety is decreased, but they tend to impair memory. Example of one of the short-acting is the triazolone. Now, as far as the benzodiazepines, you want to remember to avoid long-acting benzodiazepines in older patients. Now, your non-benzodiazepines, these are better targeted to the GABA type A receptors, so they're going to be less anxiolytic. You have a decreased sleep latency, decreased number of awakenings, and so sleep duration and sleep quality is improved. The Zolpidem has a very short half-life. It's one of the non-benzos. It's effective for sleep onset insomnia, not effective for the sleep maintenance insomnia. It's not for long-term use, and the side effects are the somnolence, abdominal pain, headaches, and dizziness, which I found abdominal pain to be interesting. The Zolpidem has a half-life of 1.5 to 2.4 hours. It's really for sleep initiation insomnia, and again, the same sort of side effects. There's an oral spray now, which is interesting, and there's a dissolvable tablet for sleep maintenance insomnia. Now, the FDA in 2013 recommended a lower dose in women, and we'll talk about that. So as far as the Zolpidem extended release, this is for both sleep maintenance and sleep onset insomnia. There's a lower dose in women, as mentioned, but this, because it's extended relief, it's recommended that these patients not drive the next day. It's not limited to short-term use, but because it's not limited to short-term use, it could be habit-forming. Now, the Eszopiclone has the longest half-life of 5 to 7 hours. In older adults, the half-life is as long as 9 hours. It's effective for sleep maintenance insomnia, but patients may complain of a metallic taste in their mouth after taking this medication. It's not limited to short-term use, and again, could be habit-forming. So, what about the sedative hypnotic side effects? As we mentioned before, cognitive impairment, the motor incoordination, the dependence, the lightheadedness, the dizziness, residual daytime drowsiness, and these complex sleep-related behaviors, which gets a lot of the fanfare and the press. So when we think about the complex sleep-related behaviors, it's sleepwalking, driving, cooking, having sex, using the phone, eating, but the patients are not completely awake when they're doing these things. So Zolpidem is like the most commonly reported non-benzo that causes complex sleep-related behaviors. And one of the studies between 2009 and 2011 showed that 12% of all emergency room visits for an adverse drug event with a psychiatric medicine was due to Zolpidem. So the FDA in 2013 also issued a safety communication. They found that if the blood level of Zolpidem was greater than 50 nanograms per milliliter, this could impair driving. And when they looked at patients, men and women that took 10 milligrams, and they looked at them 8 hours later, 15% of women and 3% of men had higher blood levels. And so the recommended lowest dose is 5 milligrams now for women. And it also suggested that you consider this for men also. So the extended release, they also did a safety communication for that same sort of study, and it was found that 33% of women and 25% of men had the elevated blood level 8 hours after use. So they recommended that the extended release be set to the low dose of 6.25 and consider that for men as well. So in 2014, even more recent safety communication was that the Eszopiclone, the 2 to 3 milligram dose was still impairing driving, memory impairment, as well as coordination, and it was lasting more than 11 hours. So they suggested that that dose needed to be decreased to 1 milligram in all patients. So the melatonin agonist, this is Ramelteon, which I looked up the price of this, and it was about $700. So if you think about from the beginning, you have a lower socioeconomic status, you're missing work, you're trying to go to cognitive behavioral therapy, which might cause you to miss work, and then this particular medication, which actually has the least habit-forming potential, is actually the most expensive. So you can kind of see some of the things that our patients may face. But in 2014, this particular medicine showed that there was an increased improvement in sleep latency as well as total sleep time. Now, the United States and Japan approved it, but the European Medicines Agency did not approve its use. And it's more effective for sleep onset insomnia, but the caution is that in patients that have liver disease, this is a melatonin agonist. As I mentioned before, it has fewer side effects, there's decreased next day residual performance deficits, and little abuse potential. Interestingly, they may have a possible elevated prolactin level as well as a decreased testosterone level. So the more novel and newer drugs are the Orexin receptor antagonists, Orexin A and B, and these are hypothalamic neuropeptides, and they're involved in regulating the sleep-wake cycle. Suvorexin, which was FDA approved in 2014, is one of this category of medications, and it has an increased toxicity with the CYP3/4A inhibitors, and there's an increased risk for dependence and abuse. And as I mentioned before, physician comfort with prescribing this, even though it's FDA approved in 2014, I don't know that I would be that comfortable prescribing it yet because there's not a whole lot of evidence about it. So what's the appropriate duration of prescription drug therapy for insomnia? Continuous therapy, the patient's taking it every night, you want to limit that to 1 month. And you want to try to taper, try to discontinue when you can. And then for the PRN therapy, you want to limit that to 6 months. And there are a lot of patients that come to the medicine clinic that have been taking this medicine for years. Maybe they came from an outside clinic, and as I mentioned, you try to take them off of it, and they're like, no, I need this to sleep, doc. So you want to avoid prolonged or excessive therapy, and then discuss the risks and benefits of drug therapy. So which medications are not recommended for routine use? And this comes up a lot too. Antidepressants. If a patient is depressed, then sure, they should have their antidepressants. But if it's a primary insomnia, the only FDA-approved antidepressant for that is Doxepin. Again, diphenhydramine is not really recommended to treat insomnia, as well as the antipsychotics and the barbiturates. So what about herbal products? Patients, they go on Dr. Google, it's like, doc, I found this, I tried this, what do you think? There's really little evidence of their benefit. The most well-studied ones are the valerian, kava, chamomile, and wuling. And out of all these, valerian has been shown to have the greatest risk of adverse events. And then you worry about cross-contaminations with other substances in this particular category. So melatonin, another one of the over-the-counter drugs, is normally secreted by the pineal gland. It's beneficial in most patients. Now, the exceptions are delayed sleep phase syndrome and low melatonin levels, but it is safe for short-term use. So how should we advise our patients about the use of non-prescription agents in the treatments of insomnia? Well, alcohol, and with it being Cinco de Mayo, I think this is a good point to make. It may reduce the sleep latency. It may improve early sleep, but there are a lot of other problems associated with it, such as the hangover the next day, not very restful sleep, and that sort of thing. Antihistamines. If you're histamine naive and you take one of these, it really can make you drowsy. There's cognitive changes as well as motor impairment. Now, melatonin, we can tell our patients this may improve their sleep onset as well as their sleep maintenance. Again, regularly structured exercise, and acupuncture and acupressure as well as Tai Chi and yoga are now starting to show some evidence of being beneficial in patients who have insomnia. And that went a little faster than I thought, but are there any questions? Any questions? Okay. And if you fell asleep during this lecture, then I'm going to assume that it was because you didn't sleep well last night. Thanks.